Alterations in cognition and sensation, head and spinal cord trauma. Head and spinal cord injuries can result in permanent or temporary disability and dysfunction. A concussion is defined as a blow to the head that jars the brain. There is temporary neurologic impairment, but with repetitive concussions, we can have a issue called chronic traumatic encephalopathy. This is usually sports related. For example, the football players that get repetitive concussions. There are some long-term effects, which include dementia, depression, Parkinson's disease, and early onset Alzheimer's. These clients will have a con- uh, brief lapse of a change in the level of consciousness and disorientation. They may have a headache. I mean, they've been hit in the head. Of course, their head's going to hurt. That would be a normal finding. Their vision may be blurred or they may have double vision. And they may have some emotional irritability or dizziness. We can do skull x-rays, CT scan, or MRI to make sure there's nothing more going on. Basically, we treat it by making the client rest, so temporary inactivity. We can give a mild analgesic. We don't want to give anything too strong, and observe for any neurologic complications. So we need to do that neuroassessment. We need to provide close observation to make sure there's no signs of increased intracranial pressure. Client instruction would include contacting the physician if there's any complications. So we would tell them what symptoms to watch for and to return to the ED if symptoms of an increased intracranial pressure occur. A contusion is going to be more serious than a concussion, and it results in bruising, sometimes even a hemorrhage of superficial cerebral tissue. We can have actually two injuries from a contusion. We can have the coup injury, which would be that direct injury where the client hits their head, and the contra coup injury. So basically, the brain bounces off the skull, and then we have an injury directly opposite from where the initial injury occurred. These clients will often experience some cerebral edema. The symptoms will vary depending on how severe the injury was. They may develop hypotension, a rapid weak pulse, shallow respirations, and pale, clammy skin. They may also have temporary amnesia. We may see permanent brain damage. We're going to diagnose with a skull x-ray, CT scan, or MRI. Their interventions are going to be just the same as with a concussion. We might give some drug therapy. Again, if we're giving drug therapy for pain, it would be a mild analgesic. And depending on the client's symptoms, they may require mechanical ventilation. So it's very important for us to periodically monitor their level of consciousness and monitor for any neurological changes. So we're looking in their eyes to make sure that the eyes are still reacting equally, making sure that they know where they're at and who they are and why they're there, making sure that they have equal strength and movement on both sides of the body. We're also going to monitor for respiratory distress and signs of increased intracranial pressure, one of which would be an increased headache or increased blood pressure. So we definitely need to be monitoring their vital signs. We also need to educate on head injury prevention, such as The use of seat belts, infant car seats, protective headgear, neck restraints, and no alcohol or drugs while driving. True or false? Contusion assessment findings include hypertension, rapid weak pulse, shallow respirations, and pale, clammy skin. This is false. That's hypotension, not hypertension. True or false? Concussion is a blow to the head that jars the brain. This is true. A cerebral hematoma is bleeding within the skull, caused by head trauma. It may also be caused by a cerebrovascular disorder. So there's different types of hematomas. We may have an epidural hematoma, where the blood accumulates above the dura. It may rapidly progress, have a rapidly progressing neurological deterioration. In other words, it happens quickly. We may have a subdural hematoma, where blood accumulation is below the dura. The patient status will progressively worsen within the first 24 hours, and we may have an intracerebral hemorrhage, and this would be a ruptured cerebral aneurysm. Bleeding will increase the brain content volume, so it can cause ischemia and hypoxia to brain tissue. And death can occur if that bleeding is not controlled. Risk factors include anticoagulation or bleeding disorders. These clients, their symptoms are going to be dependent on where the bleed is, how fast it's bleeding, the size of the hematoma, the autoregulation, which is the brain's ability to provide sufficient arterial blood flow despite increasing intracranial pressure. We're going to diagnose this with MRI, CT scan, and intracranial pressure monitoring. The body may naturally absorb the hematoma, so depending on the size, we may not have to do anything except monitor the client. But indications of emergent issues would be a rapid change in the level of consciousness and signs of uncontrolled increased intracranial pressure. We can manage it surgically by drilling burr holes to relieve pressure, and they can also remove a clot or stop the bleeding. Intracranial surgery may include a craniotomy, a craniectomy, or a cranioplasty. We should consider all head injuries to be emergencies. Nurses need to get the client's history. They need to do a neurological examination, obtain those vital signs, and determine the level of consciousness. We also need to assess the limb movement and pupil reactions. If there was a trauma, we need to examine the head and the respiratory status and do those neurological assessments. If the client has to go to surgery, it may be necessary to remove some hair, obtain those vital signs, do that neurological assessment, place anti-embolism stockings, and restrict fluids. Postoperatively, keep the client in a supine or side-lying position unless otherwise directed, and regularly monitor this client and observe for signs of increased intracranial pressure and, of course, fluid restriction. We want to minimize any edema. A skull fracture would be a break in the continuity of the cranium. This will result from a blow to the head and can be open or closed. Skull fractures can be simple, depressed, or comminuted. Basilar fractures can cause edema at the area of the spinal cord. It increases the risk of meningitis and also interferes with circulation of the cerebrospinal fluid. These clients may have a localized headache, a bump, bruise, or laceration. They may experience some hemiparesis, shock, change in the level of consciousness, or seizures because of the intracranial pressure. They may have rhinorrhea, or drainage from the nose, or otorrhea, drainage from the ears. And it's very important to assess these to make sure they are not, or it is not cerebrospinal fluid. So we put a drop on a white gauze and look to see if a halo develops around the drainage. These clients may also have periorbital ecchymosis. This is also called raccoon's eyes. Or they may have battle signs, which is bruising that is found behind the ear. These are both very classic signs of skull fractures. We may also see conjunctival hemorrhages or seizures. We're going to diagnose with our skull x-rays, CT scan, MRI. Simple fractures, we treat it with bed rest and observe for signs of increased intracranial pressure. If the scalp is lacerated, we need to make sure it's cleaned, debrided, and sutured. If there's a depressed skull fracture, these clients may require a craniotomy or antibiotics. They may also require osmotic diuretics and anticonvulsants. So the nurse definitely needs to monitor for the signs of head trauma, monitoring that drainage from the nose or the ear for the halo sign, and do neurological assessments. Hourly, we're going to assess the level of consciousness, the pupil reactions, their motor abilities, and their sensory status. Can you feel where I'm touching you? Every 15 to 30 minutes, we will be assessing vital signs. And always be prepared for the possibility of seizures with a head injury. Spinal cord injuries can be serious and sometimes fatal. Proper emergency management is critical to prevent additional damage or deficit to these clients. They're usually, they come about because of accidents or violence. It's very difficult to determine the full extent of a spinal cord injury if edema is present with the injury. So we have to wait until the edema is resolved before we can determine just how extensive the damage might be. Complications of spinal cord injury can include spinal shock or areflexia. This will be seen immediately. It's a transient response to injury in which the reflexive activity below the level of the injury temporarily ceases, but it can resolve in days, weeks, or months following the injury. There may be a loss of all cord function below the site of the injury, and we see hypotension and bradycardia, a lack of perspiration below the injury, which can affect the temperature control, and it may last a week to months. With autonomic dysreflexia or hyperreflexia, this is more serious and it's potentially dangerous for the spinal cord client. It's emergent. We have an exaggerated sympathetic nervous system response in injuries above T6. They have severe hypertension, bradycardia, headache, nasal congestion, blurred vision, seizures, stroke, and death if it's uncontrolled. Spasticity is something else we also see with our spinal cord injuries. This will be increased muscle tone, and it's experienced to some degree by most clients that have a spinal cord injury, and they're exhibited through muscle spasms, even in someone who is paralyzed. Other complications of SCIs include pressure injuries, respiratory infections because they're not able to move, bowel and bladder impairment, contractures, weight changes, and pain. These clients will have, again, we won't be able to determine the degree of disability until edema is resolved, but it's also going to be dependent on the level of the injury, which is indicated by the vertebrae the injury is located at. The client may have brief lapses of consciousness, disorientation, headache, blurred or double vision. They may have emotional irritability and dizziness. They may have pain, difficulty breathing, numbness, and paralysis. They may have edema and bleeding, which can lead to cord compression. Again, diagnosis with X-ray, myelography, MRI, a CT scan, and neurological examination. The goal of treatment will be to save the client's life while we are preventing further injury to the cord and preserving as much cord function as possible. We'll need to place a cervical collar, maybe a cast or a brace, maybe traction or a turning frame. We need to initiate an IV, obtain vital signs and stabilize them, administer corticosteroids. Methylprednisolone is a steroid that, if administered within 8 hours of the injury, may reduce the damage to the cellular membranes and help clients regain some function. But treatment with this medication is controversial right now. And of course, these clients will require physical therapy and occupational therapy. Surgically, if there are bone fragments, they may need to be removed. If the vertebrae are just dislocated, then we need to repair that. As nurses, we always observe for neurological complications. We need to make sure that cervical collar stays on. It is not going to prevent movement of the head and neck, but I always tell my clients, I'm going to put this on to remind you not to turn your head, not to move your neck. We may have to do spine stabilization. In fact, we should with spinal cord injuries, which means that we're log rolling the client. We have a client who is managing the head. They're the ones in charge. They're going to say, turn to the right on my count of 3, etc. And then, of course, we need to make sure the client remains immobilized with a cast or brace. Spinal nerve root compression. This can happen from trauma, might happen from herniated intervertebral discs or tumors of the spinal cord. These clients may experience weakness, paralysis, pain, and paresthesias. We can diagnose this with spinal x-rays, CT scan, an MRI, myelography, and electromyography. Again, we are going to use conservative treatment first. We don't just jump in with the scalpel and want to do surgery. Put the cervical collar or brace on postoperatively. Put the client on bed rest. They may require skin traction and hot, moist packs. We can administer skeletal muscle relaxants, drug therapy, corticosteroids, and analgesics. They will require physical therapy and pain management. Different types of surgery that may be done would be a discectomy, where we remove a ruptured disc, a laminectomy, where we remove the posterior arch of the vertebrae to expose areas of concern, or spinal fusion, where we graft the bone to the vertebrae to fuse the area. As nurses, always do that neurological examination. We're messing with the spinal cord, so we need to make sure that we have not caused further problems. Conservatively, spinal support and alignment. When they're resting in bed, put them in the semi-Fowler position. Um, Make sure they use proper body mechanics. Give those medications like the muscle relaxants and analgesics, applying that moist heat. And evaluate how they are doing after therapy. Postoperative, monitor vital signs, do hourly deep breathing exercises. Make sure you're examining the dressing not only for bleeding, but for cerebrospinal fluid. Assess the neurovascular status. How are they voiding? And use a fracture bedpan because they're going to be on bed rest. Postoperatively, how often should deep breathing exercises be done for a client who had surgery for a spinal cord injury? Hourly.